Good night. Hi, people. Alejandra, Dorian, Diana, Laura, and Pablo. Let me see, do you want to wait for your classmates a little bit, or do you prefer to start now? What shall we do? Do we start, or do you prefer to wait a little bit? Please let me know by a message, by talking, that's okay.
I think that we can wait a little bit for the other classmates.
Okay, let's wait 3 minutes more, I think, and it's gonna be enough, okay? I think it could be a good moment, a good period of time. Okay, let's start. Let me see, can you watch my screen?
Yes, Miss.
Okay. We are going to work tonight from my cell phone but I don't know, I cannot open my Zoom profile from my computer, but well, the cell phone works. Let's do it in our best way, okay? As soon as I can change device, I'm gonna stop the presentation and change it in order to improve this situation. Okay, let's go. Today, we have long topics to check, but as you know, it's a general view just. The general view in order to make easier and make faster with the basics. Tonight, we are going to see the nervous system, the mental illness, blood, and oncology. Okay. Let's talk about the nervous system. Nervous system, as you know, is, in my opinion, the most important system from the body. And while we all know that we have this chance to see, to work on, and we know that the brain is divided into hemispheres, the left and the right. In that way, every part has its own activities, own functions. And here, this chart is very, very common, we can say. And we have the chance to practice on this and try to understand how each hemisphere works. Of course, anatomical review, we got the red guy in order to punctualize that we have the chance to practice, to memorize maybe the parts of the central nervous system. But we have to go from the smallest part, the anatomy of a neuron, with all of these, its details. The soma, the cell body, the cell nucleus, the axon terminal, the synapse bottoms, the Schwann cell, the myelin, and then the point of synapse. And we have all of these details that we must check, okay? Now we have this chart. When we can notice the type of neurons, the ACE, the afferent, connecting, and efferent neurons, just for extra information, for catching vocabulary in a proper way. And then we have the neuron functions, the SAM, the SAM, the sensory neurons, associative neurons, and motor neurons. Read this, it's gonna be helpful, okay? Then we got the anatomical chart, the biggest one with the most important neuronal branches and roots for checking the common names, okay? The most important, the common ones. And now a small detail, a cross-section showing the structures from the brain. Okay, well, we all know about it, just for making the review. Another one with more details for practicing. And now we have these brain parts and their functions, just for practicing, for catching the meanings, for checking how it's written and how to express these details. So I think it's important, and at this point it's going to be useful. Now we get the cranial nerves. So in Roman numbers, of course, and then we have to check the area when they are growing up and how on the functions they develop. Okay, you again. Now we have the difference between dermatome versus myotome. We all know this from the medical school. This is an extra chart for catching vocabulary, but could be interesting to read this. Dermatome refers to an area of skin innervated by the nerves from the single spinal root. Just one, as you can see in the picture. The myotome refers to a group of muscles innervated by the nerves of a single spinal root. Then you can check the myotomes. The dermatomes, for example, C4, C5, C6 are signed, and the myotomes, you can check C5 and all the color, how the color is working on, okay? Well, another difference. A region of the skin innervated by a single spinal nerve is the dermatome, and the myotome, a group of muscles innervated by a single spinal nerve. Okay, then we got some dermatomes consist of overlapping regions innervated by more than one spinal nerve. You can check the picture. And checking the myotome, some are innervated by more than one spinal nerve. It's very interesting while practicing, while checking and making the physical exam, how we can develop these differences. We continue with anatomical review again, now checking the spinal cord and how it's shown through the body, through the thorax, abdomen, and pelvis, of course, and then the spinal cord as a fact in colors for checking the different roots, okay? Now we got the parasympathetic nerves and the sympathetic nerves. We all know it's how they work, just for making a review, for checking how they are innervated and which roots are coming from. Now we got this, the structures, combining forms and functions. We got the brain as a major structure, and then we get the related combining form, cerebro or encephalo. The spinal cord is myel or myelo, nerves, neuri or neuro. As a plus, we got the sensory organs and receptors, eyes, ears, nose, and skin. Well, here I forget one, but don't worry. The touch, okay, well, patience. Then we got the root part, the word parts, I'm sorry. When we got cause or causal, it's burning. Cerebro, concuss, I mean shaken together, violently agitated, for example, concussion. Contussed, bruise, the contusion, of course. The encephalo, the hypensthesia, the suffix, sensation or feeling. The stero, feeling or nervous sensation. Hypengraphy, another suffix. Well, we got meningo, myelo, neuri or neuro, phobia, psycho, radiculo, tropic. Okay. So check this, practice on this, check the meanings, please. Now we got into this first concept, first ideas to catch the meanings. We have the tendon reflexes. While practicing, we always made and develop these maneuvers. We have the chance to evaluate how the peripheral nerves are working, making this evaluation. So we know that it's the examination of the nervous system normally includes testing the deep tendon reflexes. For example, the knee jerks. The jerk is that movement when you give a kick involuntary, right? When you stimulate the nerve and you get it, you get the movement, that movement is the jerk. With a tendon hammer, also known as a reflex hammer. There are different ways of working. All of them has its own objective. We know about it. Now for checking this, we got these ideas. The reflexes may be absent. We qualified it by a 0. Diminished, that hyphen. Normal, a plus. Brisk, 2 or 3 pluses. And then we check the plantar reflexes are also checked, of course. The normal plantar response is down going. You know, going down, right? That's movement, down going movement, okay? Then the upgoing movement to the toe is the extensor or Babinski response is abnormal. We know about it. So we must take it in count. We have this chart for showing what the grade of the tendon reflex and how we can report as we were checking. The 0, no response. 1 plus could be something diminished lower than normal, 2 pluses average, 3 pluses brisker than average, and 4 pluses very brisk hyperactive with clonus. As you can see, this chart and this second one are different ways to evaluate, but both of them go to the same objective, to show how tendon reflexes are moving, how the jerk is present. It's just for extra information. We check the depth tendon reflex, the muscle evolved, the nerve supply, and the root supply. It's for catching the idea. I'm not going to take it in account for any evaluation, so don't worry about memorizing this. It's just for information, okay? Now let's talk about the motor system. When we talk about it, we consider the movement, right? We say that the motor system, while evaluating, is the examination of the motor system should include assessment of the following: muscle bulk, amount of muscle tissue, and then we have to look for signs of wasting, muscle atrophy. As you can see, we have the picture with the normal muscle, a normal quantity of muscle, a normal amount, and an atrophied muscle according to a pathological situation could be or not being so well fitted. There are many situations to get on this situation, we can say. Then we evaluate the muscle tone. We say that is the amount of tension in a muscle when it's relaxed. The tone can be increased, it's in spasticity, or decreased in flaccidity. So considering this, we know how they work. I mean, we were checking in previous slides that we have movements that are opposite to them according to the groups, to the muscle groups. So with that idea, we can evaluate the muscle tone properly. Then we have the muscle power, of course, the strength, and the strength is very close related with the muscle tone, of course. And now we got the coordination, one of the most important activities for the nervous system. Is the ability to use several muscles at the same time to perform complex actions. For example, gait, the manner of walking reflexes, or making different movements that are activating different parts of the body, of the brain. So as you can see in the pictures, we have we can say an elderly guy practicing exercise and practicing coordination, making the contralateral or the ipsilateral coordination that is very important in order to practice, or making the coordination with head and feet, eye and hand. So it's important to consider this. Then we got the involuntary movements. Well, at this point from my cell phone, we cannot check, but this slide was with movement. When talking about involuntary movements, we know that there are movements that we cannot control. For example, tremors, myoclonus, tardive dyskinesia, tics, atetosis. So following this, we know that some of these situations are, well, could be because of stress or many other situations around the central nervous system. Now I have this difference, the spasm and twitch. And the spasm, well, the muscle spasm is a long contraction resulting in chronic pain. It's continuously happening, and it's because of a pathological situation. The contractions in the spasm are long and persistent, and greater pain in comparison to a twitch is so hard. For example, elderly suffers from a spasm according to the weather, for example, could be. On the other hand, we have the twitch. The twitch is, well, the muscle twitch is a short contraction resulting in mild pain and can be seen below the skin. We can stimulate the twitch, by making a pressure and leaving away the muscle becomes in a small contraction. It's not so long, I mean. Contractions are short and mild and pain relatively less. In order it's shorter in time, it's possible to control pain easily than in a spasm. Okay, the key report of a patient. Well, we were supposed to talk about it in the previous workshop, but only one student or two sent me the key report, the writing exercise done. Tomorrow we are going to check it in detail. Now just focus on the blackened words and let's read. On examination, her face showed little or no expression. There was a tremor affecting mainly her right hand, and she had generally increased muscle tone. Power reflexes, coordination, and sensation were within normal limits. Examination of her gait showed that she was slow to start walking and had difficulty stopping and turning. So you can see this is specific vocabulary. Expression, affecting, general increase within normal limits. Let's take this vocabulary in count for working properly in next situations, okay? When we talk about the motor loss, we must consider these situations. The first of all, the weakness, the loss of power. Lots of situations for that could be because non-sleeping or non-eating properly. Well, we know. Then we got the paralysis, the complete loss of power because of brain situation. We know if the right part of the body is without movement, the affection on the brain could be in the left side, right? Then we got the tremor, involuntary rhythmic movement, specifically of hands. Maybe we had the chance to check during the med school, but it's important to remind us. Then we got the abnormal gait, unusual manner of walking. Okay. There are many ways of gait, many details to check, but now it's a general idea. If you have a patient with an abnormal gait, well, following the normal step, the normal gait they are doing, we can get an idea what's wrong, which pathology specifically does, okay? Talking about the symptoms of aphasia, well, we check this. The speech may also be affected, for example, with hoarseness, a rough, deaf voice as vocal cord paralysis. Slurred speech means pure articulation as in cerebellar disease. We all now have the chance to hear hoarseness. For example, when you get amygdalitis or laryngitis and your voice is going down and you sound so rude, that's hoarseness, okay? Hoarseness is so common. We all had the chance to read, but when it's continuously without any pathology in the vocal cords, well, we know that there's a paralysis in the vocal cords, of course, and then the voice is changing sound. The slurred speech is talking, well, when someone talks and you cannot understand properly because pronunciation is not so clear, okay? Some other symptoms could be trouble speaking clearly, the slurred speech, trouble understanding speech, okay, trouble writing clearly, trouble understanding written words, trouble remembering words, and trouble remembering object names. Maybe you had the chance to check many of the symptoms with elderly patients. Okay, so let's might consider this. This is just an information slide when we have the motor and non-motor symptoms of Parkinson's disease. We know we got the primary motor neuron, the secondary motor neuron, and the premotor neuron. Following where the affection could be, we had the chance to check how to treat this. It's just for information, check this. I'm not going to consider this specific slide for homework or test. about the sensory loss, very important, this chart, okay? We must consider this detail. We have the hearing as a function. And when we lose the hearing, we got deafness. Symptoms that can go with this are buzzing or ringing in the ears, tinnitus, okay? We got the sight as a function, and the loss is blindness. Other symptoms that could be related: double vision, diplopia, blurring, loss of visual acuity, or loss of clarity of vision, okay? When we got the sensation as a function, the feeling, the loss is numbness, the anesthesia, numbness. Symptoms that are related: tingling or pins and needles, paresthetic, the paresthesia, okay? The function balance, the loss is unsteadiness, the ataxia, unsteadiness, okay? Then we got the other symptoms: dizziness, the vertigo. Well, there are no common words for loss or conditions relating to taste and smell. So loss of taste, loss of smell is the way to express this sensory loss. So when we talk about hearing, sight, feeling, and balance, we have specific words, okay? Let's try to study this properly. And now we got this syndromes of sensory loss. Just for information, don't worry about it. It's for your reading. It's for you, the extra information, okay? Now let's talk about the loss of consciousness. The loss of consciousness, of course, is a very common situation, and we must talk about it properly. We must identify two situations and ways to express these ideas. For example, patients may describe sudden loss of consciousnness in a number of ways. I mean, when they know that they are, well, when they don't know why they got the loss of consciousness, and when they know they had a diagnosis that is supporting this loss of consciousness. If they don't have any idea and it's the first time that it happens, patients usually say, I passed out, I had a blackout, I fainted. These three common expressions are for patients who never had it previously, could be the first time, and they certainly don't have the reason why it's going on. On the other hand, when people have they know the diagnosis or the pathological situation, the surrounding, they could say, I had a fit, I had a seizure, I had a convulsion. Can you notice the difference? Let's consider this. Fit, seizure, and convulsion, all of them are all used to refer to violent, involuntary movements as in epilepsy, okay? We as doctors could ask, when did you lose consciousness? And you have the chance to receive the answer that the patient was considered. They could tell you, I don't know, I passed out, or they could say, I had a seizure. I know I have epilepsy. It's according to the situation and the patient, of course. And now I have this chart, I think very important, because we are checking the difference between epileptic fit, syncopal attack, or fainting. Syncope is a sudden loss of consciousness due to temporary failure of the cerebral circulation. Syncope is distinguished from a seizure principally by the circumstances in which the event occurs. So we know it's not the same the syncope than the seizure, right? For example, syncope usually occurs whilst standing under situations of severe stress or in association with arrhythmia. Sometimes a convulsion and urinary incontinence, loss of control of the bladder, occur even in a syncopal attack. Thus, neither of these is specific for an epileptic attack. The key is to establish the presence or absence of prodromal symptoms or symptoms that occur immediately before the attack. Syncopal episodes are usually preceded by symptoms of dizziness and lightheadedness in epilepsy. People may get warning known as aura that an attack is going to happen. So check, the non-convulsion is often used in plural form. He had convulsions as a child. Why in plural? Because we usually have many episodes of convulsions and then we get the chance to talk about it. Checking this. We got the prodromes, we got the background, we got the pathophysiology, just for extra information. For example, checking the background. Sudden loss of consciousness caused by certain triggers. The triggers, that situations that make something to happen, okay? Will be the result of temporary decrease in blood flow supply to the brain. Prodromes usually associated with trigger event. The trigger events could be, for example, too much noise, excessive changing in lights, excessive, and a specific smell, and a specific, I don't know, a specific movement could be that kind of triggers, okay? Prodromes, dizziness, lightheadedness, sense of being warm or cold, suddenly, of course, while changing from a place to another, pallor, nausea, sweating, palpitations, blurry vision, hearing changes, but all of these prodromes tell the patient that is going to suffer a seizure. And they have the chance to prepare and not have a trauma on this. Well, we know the pathophysiology, check this for you. Check the specific vocabulary, please. It's in order to improve, to catch specific ways to talk about situations. Now we got these acronyms. When we can check the causes of syncope, okay? The cardiac causes, orthostatic, neurocardiogenic situations, of course, seizures, neuropathic dysautonomia, or other causes like mechanical or glucose levels, the cerebrovascular or vertebrovascular ischemia. Just check, it's extra information, okay? Now let's talk about coma. The coma, we know, is unconsciousness with a reduced response to external stimuli. Doctor says the patient is in a coma, or in another way, the patient is comatose. Okay, that's the two common ways to express this situation. We all know the Glasgow Coma Scale from med school. Just for checking how to express this, the scale is one of the most important. You got this, practice. Well, this is the trauma coma. Is a criteria for deciding when a patient is really in coma or not. Of course, we have criteria on this, just an extra slide for practicing. Now we got this chart showing you the normal consciousness, how they work, the vegetative state, the lock-in syndrome, and the brainstem death. Extra information again for practicing, for checking. And now let's see the pathologies of the nervous system. We got the head and meninges, cephalalgia or headache, migraine headache, cluster headaches, encephalocele, meningocele, hydrocephalus, meningioma, meningitis. Disorders of the brain, mild cognitive impairment, dementia, the senile dementia, vascular dementia, encephalitis, Reye's syndrome, tetanus, Tourette syndrome, neurodegenerative diseases, Alzheimer's disease, Parkinson's disease, PD, and Huntington's disease. Brain injuries, amnesia, concussion, cerebral contusion, cranial hematoma, epidural subdural hematoma, or traumatic brain injury, considering the COOP, Cotter-Coop or Cotter-Brown, the shaken baby syndrome, of course. According to the levels of consciousness, we got conscious, unconscious, lethargy, stupor, syncope, coma, persistent vegetative state, and delirium. Just a small view of the pathologies of the nervous system. And we got the brain tumors, malignant brain tumor, benign brain tumor, intracranial pressure. Then we got the pinched nerves, radicularis, could be cervical radiculopathy, lumbar radiculopathy, multiple sclerosis, demyelination. Then we got the strokes, cerebrovascular accident, the ischemic stroke, the TIA, the transient ischemic attack, aphasia, hemorrhagic stroke, arteriovenous malformation, then the cerebral palsy, sleep disorders like insomnia, narcolepsy, sleep deprivation, somnambulism, epilepsy and seizures, tonic-clonic seizures, absent seizures. Just a small view, right? The spinal cord, myelitis, myellosis, polymyelitis, post-polymyelitis syndrome could be spinal cord injuries. Abnormal sensations could be causalgia, hyperesthesia, paresthesia, peripheral neuropathy, restless leg syndrome, RLS. Then we got the nerves, amyotrophic lateral sclerosis, Bell's palsy, Guillain-Barré syndrome, neuritis, sciatica, trigeminal neuralgia. You can see it's very, very small chart on this. We got the abbreviations, the common ones. Please practice on them, check on them. Now let's go to the mental illness. We know they are now common, we can say, in these themes nowadays. Someone who has not a mental illness, a mental disorder is not normal one. We all have something and it's new. The one who has anything is the strange guy at this point, right? The most common situations in adults could be said: depression, panic disorder, schizophrenia, post-traumatic stress disorder, bipolar disorder, dementia, and phobias in all of these contexts. Signs of mental illness in general for everything could be appetite or sleep changes, extreme mood swings, chronic low-grade depression, hallucinations and or delusions, unhealthy coping mechanism, unusual emotional outbursts. Okay. According to the age symptoms, the mental health disorder may be different, of course. The differences are according to the situations that the patient is living on. Going into psychiatric disorders, we are going to check dementia. Just as an example. For example, we can divide the psychiatric disorders in organic and functional. Dementia is a mental disorder due to organic brain disease. The commonest form of dementia is that associated with old age, the senile dementia. Disorders in which there is no obvious pathology or anatomical change in an organ are termed functional. So you know, if the organ is affected, we can check this. According to the age, the senile dementia, it's easy. Some symptoms could be changes in memory, changes in perception, changes in reasoning, in attention or concentration, changes in thinking, changes in judgment or in language. If they interfere in a person's ability to function, we must consider the probable dementia that the patient is suffering from. This chart is showing you some psychiatric disorders and some neurological disorders. Here you have the chance to check some abbreviations of the most common situations, and then how to understand they could change. For example, we got the post-traumatic stress disorder, obsessive and compulsive disorder, the Tourette syndrome, the anorexia nervosa, anxiety disorders. Okay, so we must consider this in the way they are psychiatric situations. The neurological could be migraine, epilepsy, stroke, multiple sclerosis, Parkinson, Alzheimer's disease, in order to understand that they are generic. Some of these psychiatric disorders could be generic, could be into the line of family, but it's not always possible to clarify if they are or not in that way. Now we got the difference between Alzheimer's and Lewy body dementia. Just for making the comparison, an extra slide for practicing. And now let's check this. That's an important topic, the substance abuse. Abuse of substance means using it in a way that is harmful. The commonest forms of substance abuse are alcoholism and drugs abuse. The most common ways, right? When we check both of them, we consider the signs of addiction. The behavioral changes, the common ones that we can see in this situation are secretive behavior, inflexibility with plans, lying about plans, financial troubles, stealing money or substances, isolating, disregard for others. So you can see, if you analyze a patient who has this difficult situation, you can notice all of these symptoms, all of these signs. So just for checking, we have the second chart when we have this poor academic performance, the drastic changes in weight, money problems again, withdrawal from friends and activities, trouble with the law, violent outburst, excessive sleepiness could be. In this slide, we're checking the affective disorders as ideas, as a concept, okay? We have Lacan words again to memorize or to practice these specific words. Affect and mood are similar in meaning and refer to the emotions. For example, happiness or sadness. Affect tends to be used for temporary emotions and is expressed through manner of speaking, facial expression, or behavior. On the other hand, mood is used to refer to a more permanent emotional state. The most common form of affective disorder is depression. The symptoms in which are poor appetite or significant weight loss, sleep disturbance, for example, insomnia, or fatigue, the loss of energy. Psychomotor agitation, excessive movement, or psychomotor retardation, slowing of movement and thought. Loss of interest in stimulating activities, decreased ability to think and concentrate, feeling that one is no value to others or that one has done something wrong, and recurrent thoughts of death or suicide. 5 or maybe 4 of the above symptoms occur nearly every day for at least 2 weeks, constitute a major depression. Okay, check this, try to practice on the vocabulary and memorize. Checking the mood disorders, the types are the next. Bipolar disorders, seasonal affective disorders, chronic depressive disorder, anxiety disorder, psychotic depression, postpartum depression, the most common ones. Now we got the neurotic and stress-related disorders. When we can check. As an example of neurotic disorder is the obsessive compulsive disorder. An obsession is an idea that is so persistent that it interferes with the patient's life. A compulsion is an obsessive idea that forces the patient to act even though they recognize that it's unnecessary. A common form of this compulsive washing of the hands could be stress is a feeling of being unable to cope. It can lead to anxiety or fear of problems. A sudden attack of anxiety is called panic attack. Then we got this slide showing the symptoms of neurosis. Please check this and the common signs of neurosis. Checking this information, you are going to identify maybe easily if someone is suffering from these situations. The acute stress disorder symptoms are in these slides and the post-traumatic stress disorder diagnostic criteria. It's just for information for practicing. Tomorrow during the workshop, we have the chance to practice on this slide, okay? Other types of functional disorders may include behavioral syndromes associated with physiological disturbance. For example, eating disorders. We can check excessive exercise while talking about the potential signs of an eating disorder, preoccupations with feeling fat, abnormal electrolyte levels, intense fear about gaining weight, unusual, give me a second, unusual large food intake, anxiety around of avoidance of food, okay, of eating. So we must consider this. It's a very common situation nowadays. In teenagers, maybe in our family, we got a chance to see this situation. I had a friend who has anorexia and, well, she couldn't control this even though the therapy and finally died because of the abnormal electrolyte levels. She was extremely thin. We know that the extreme cases all around the world, they are famous. We can check in the internet how they work, right? Now we got this slide when we can check the disorders of adult personality and behavior. These personality disorders, why I decided to send the princesses of Disney. Because, well, following some psychiatric ideas, we got the chance to realize that all of them have one psychiatric disorder in personality. For example, Bella has the Stockholm syndrome. She was in love, well, she got in love with her captor. Then Ariel, for example, decided to change herself completely for falling in love with a guy that she didn't met. Actually, she saw him once and then she fell in love, right? Then, for example, Mulan of her family and making them proud. So as you can see, if you study this theory, you can see how it works. Okay. Let's check the mental retardation, delayed mental development. Of course, we know that it's not a very common, very comfortable situation to talk about, but we have to ensure that it's nowadays, well, easy to recognize, maybe, according to the phase, to the syndromes they are following, right? They are living on. Then we got the schizophrenia and other disorders in which there are delusions. I mean, false beliefs. The common symptoms of schizophrenia could be delusions, hallucinations, disorganized speech, then flattened affect, reduced speech, lack of initiative. they really need a support for going ahead and ensure that someone is with them. Schizophrenia in children, of course, happens. The common symptoms are delusions, flat affect, bizarre behavior, hallucinations, paucity of speech or thought, disorganized thinking. Okay, let's continue. And it's blood. We're going to check the most general ideas about blood. For example, we have the FBC, the full blood count. It's the simplest test in investigations of blood. And well, in a sample of blood, you can check the amount of hemoglobin, the number of different cells, could be RBC, red blood cells, the erythrocytes, white blood cells, the leukocytes, the platelets, thrombocytes, the volume of the cells, of course, and the erythrocyte sedimation rate, the ESR, measurement of how quickly red blood cells fall to the bottom of a sample of blood, okay? Now we got the anatomical review, of course, the detail we have to practice by our own. And now we got this slide, the anemia and the anemia. The pronunciation is the same. The only detail is the A, the second A, anemia and anemia, okay? Is the most common disease of the blood. It may be due to bleeding, excessive destruction of red cells, or low production, okay? Now we got this dialogue in order for practicing, please, when you have the chance to check the differences. Okay, just check and try to identify the specific terms they are using. This dialogue supports discharge, the pernicious anemia, the PA, okay? In black and words, we have the specific word we have to check, similar to the previous boxes charts we were checking in previous presentations. Pernicious anemia is a condition in which there is atrophy of the gastric mucosa with consequent failure of intrinsic factor production and vitamin B12 malabsorption. The onset of indicious with progressively increasing symptoms of anemia. Patients are sometimes said to have a lemon yellow color owing to a combination of pallor and mild jaundice caused by excessive breakdown of hemoglobin because of ineffective red cell production in the bone marrow. A red sore tongue, glossitis, is sometimes present. Patients present with symmetrical paresthesia in the fingers and toes, early loss of vibration sense, and progressive weakness and ataxia. The spleen may be palpable. Great. We got black and words again for memorizing the specific meanings. You have the meanings in the list. Please practice on this, okay? And now we got this grammar tip. In this grammar tip, well, we analyze the verb reduce. And reduce has several meanings. In medicine, for example, reduce could be make smaller. We'd better reduce the dose of your tablets. We'd better take less tablets, right? Less doses. In surgery, reduce could be return on an anatomical position. A hernia can normally be reduced by manipulation. Great. In chemistry, to remove oxygen or add hydrogen. Nitrous acid is a reducing and oxidizing agent. Well, that's the idea. In chemistry, we also can say reduce. It's not just one meaning. According to the context, we have the capability to understand this. Now let's check a very small detail about oncology, a very, very fast view. When we check this, the neoplasms, abnormal new growth of tissue, right? It's a neoplasm. Malignant neoplasm is cancer, are likely to spread and cause serious illnesses or death. Okay, the benign neoplasm do not spread and are less harmful. When speaking to a patient, doctors generally say growth or tumor. That's the common way to give this idea. We can say you have a small growth in the bowel. You have a small tumor in the bowel. Okay. Now we are going to consider this specific word, a lump or swelling. Both of them can be considered as synonyms. Lump or swelling is a collection of tissue or fluid which is visible or palpable. Okay. A lump may be due to a neoplasm. Usually, well, this, you can see the mouth and the plate, we got a mass. This mass could be called a lump or swelling, okay? A lump may be due to a neoplasm. There are other causes such as inflammation or fluid accumulation. That's why, according to the situation, we choose lump or swelling. Patients say, I have a lump in my left breast. And the doctor says, there was a firm, palpable mass in the liver. Okay. Then we got this. Malignant tumors are characterized by rapid growth and invasiveness. The tumor may invade local tissues or may spread to distant parts of the body, the metastasis, of course. Neoplasms, which are the result of metastasis, are called secondaries, as opposed to the original tumor, which is the primary. We can check this bubble when we are receiving the idea of a doctor. We have the results of the scan back. Now I'm afraid they show that you have a small growth in the prostate. Fortunately, it appears to be an early stage and there is no sign of spread. So if we remove it, there is every chance of a complete cure. Checking this grammar fact, to invade as a verb is to enter and spread throughout a part of the body. And this process is invasion as a noun. Invasion is a noun. If a tumor is described as invasive, okay, it has the ability to spread. Then we got this chart showing you how a benign tumor and a malignant tumor for making the comparison just. And now we have the symptoms and signs of malignancy. Well, all of them may be related to the, for example, space of annihilation in the brain causes raised intracranial pressure and symptoms such as headache, vomiting, or visual disturbance, according to the place in brain. On some of them, as the picture says, could cause vertigo, seizure. The common symptom of brain tumors are headaches, okay? Tumors of the colon, for example, may obstruct or may block the lumen and cause change in bowel habit, okay? Other possible symptoms of malignancy could be bleeding, pain, and weight loss. In this chart, we are checking a very fast view. We got the respiratory symptoms like cough, hemoptysis, and dyspnea. The lymph nodes, lymphadenopathy, big lymph nodes every place in the body. The liver with hepatomegaly and jaundice, and skeletal pain, fractures that are, well, pathological fractures, spinal cord fractures by compression commonly. Signs of brain cancer, you got all of them. Signs of colon cancer, you got all of them again. Lung cancer again, and breast cancer. Please read all of these signs. I'm going to ask for them during homework and the final test. It's important to check this specific vocabulary, okay? And now we got this. Well, you have here, I'm sorry, my internet connection is not so fast at this moment. But now there are the charts, the signs of brain cancer, colon cancer, lung cancer, and breast cancer. And now we got, yes, this case. In this case, we are checking the breast cancer in males. Of course, it could happen because during the pregnancy, when the fetus is growing up, at the beginning of everything, we are embryos. We both have mammals. So we could have this situation. It's not common, of course. Following this case, it says a 33-year-old man presented to his GP complaining of painless lump on the right side of his neck, which had been present for about 2 months and was enlarging. He had been feeling generally well and had lost about 5 kilos of weight. He was also complaining of night sweats. He had no significant past medical history. Well, yesterday we were talking about the as a past view about the way to write down a case report, and you can see everything in past, and it has details that we were checking yesterday. Tomorrow we have the chance to practice on this. Okay, we have this chance. About the treatment of tumors, well, a tumor can sometimes be completely removed or excised by surgery. If it's not possible, of course, because it will happen, maybe it has metastasized, or it may be possible to destroy it by radiotherapy or by chemotherapy. When a cure is not possible, palliative treatment is given, which is only intended to relieve symptoms. In the chart, we are checking the cancer treatment options: hormone therapy, surgery, bone marrow transplantation, chemotherapy, targeted therapy, radiotherapy or radiation therapy, and immunotherapy. And well, I think it's important to see this slide. Slow down and keep calm. We can do this. Just take it easy and keep on practicing, okay? It's a lot of information. I know it's a lot of details to check. And well, we have the chance to practice on this. So it's almost time. So let me send you the pool to take attendance. Where is the pool? Okay, can you all watch the pool? Okay, I need a pool. Can you all watch the pool, or someone has the trouble with this? Okay, great. Everybody feel this. Thank you. I'm gonna send the presentation to your WhatsApp following the attendance, okay? So yesterday I was supposed to send a file. I'm gonna send it tonight. I'm sorry, I'm out of mind at this point, but I'm gonna send it again to the WhatsApp according to the attendance to the workshop. And as you know, tomorrow is the presentation of homework to the ones who didn't send it yet. So moreover, I'm gonna, following the attendance, I'm gonna check the role, the workshop role, and it might change because there are schedules, well, one schedule when people is not attending, I don't know why, or when there were supposed to be 3 and there are just one person. So we are going to change it in order to work properly, okay? So Give me some minutes, please, and I'm gonna send the slides to your WhatsApp, to the ones who are here. That's all. So see you tomorrow, okay? Bye-bye, people.
Thank you. Bye.
Bye.
Teacher, sorry, the material are you going to send us in this place or in WhatsApp group?
No, today, because I have troubles with my laptop, I'm gonna send it to your personal WhatsApp according to the attendance. So if you are here, I took
Yes, I
attendance.
was on time, teacher. Okay.
Yeah, don't worry, Len, I'm gonna send it to you.
Okay, thank you. Bye.
Okay, bye-bye. Okay, I'm gonna close this.